We shall be reading about glaucoma. Glaucoma is a group of eye disease which results in damage to the optic nerve and cause vision loss. Because vision loss due to glaucoma cannot be recovered, early detection and its management is very important. Glaucoma is often called the silent thief of the sight because most of its type typically cause no pain and produce no symptoms until noticeable vision loss occurs. This is a disease of concern because worldwide 80 million people are suffering from glaucoma, and in India also around more than 11 million people are suffering from the disease. Aqueous humor is secreted from ciliary epithelium here, and this maintains the intraocular pressure and inflates the globe of the eye. This provides nutrition for the avascular ocular tissues like cornea and lens. And the drainage route for aqueous humor flow is first through this posterior chamber. From here, it passes through pupil and enters into the anterior chamber. And from here, it passes into the trabecular meshwork. And from this trabecular meshwork, this reaches into the Slim's canal here. And through this, it goes through the episcleral vein to the cavernous sinus. Some volume of the aqueous also takes a different route. It goes through suprachoroidal space and gets absorbed into the suprachoroidal blood vessels and through episcleral vein also. Most of the intraocular pressure is around 15 to 21 millimeter of Hg. And most of the patients of glaucoma are asymptomatic, but many patients can have blurred vision. And one of the important symptom is colored halos, a halo around the light, and pain around the eyes or intermittent headache. Patient may complain of as vision is not good as in the other eye, or there is early onset of near vision problem. We call it presbyopia, or frequent change of glasses and occasional blurring. And most of the glaucoma patient might say that they have family history of glaucoma. And if the patient is on steroids, either topical or systemic, you should be alert that the patient may be having raised intraocular pressure. And any history of trauma and intraocular surgery can also be cause of raised intraocular pressure in the eye. The risk factors of this glaucoma is one of the important association is with age. People in India over 40 years of the age may be having glaucoma. Similarly, the race is another important cause of association. Darker the race, more is the chance of glaucoma, especially in African population and Asian populations. Family history is, we have discussed, it is an important risk factor. Normally, intraocular pressure is around 15 to 22 millimeter of Hg for the most of the population. So we have to measure the intraocular pressure for all the patients in which you suspect the disease or any patients with high risk association. So we have an indentation type of tonometer in which the cornea is indented by weight here, and this gives resistance because of intraocular pressure. If the intraocular pressure is less, this will get indented more, and if the intraocular pressure is high, there will be resistance to the indentation. Let us suppose the reading is at 5, and from here you can refer to a chart especially prepared for this. From 5 it is 17.3, so you can say that it is 17.3. This tonometer is called Seward's tonometer. Tonometer is Aplanation tonometer, in which a specific area of cornea is flattened by giving pressure over the cornea, and this is flattening is accurate or not is seen by coloring the use of coloring the tear film with the use of fluorescent dye. This is the tonometer attached to slit lamp, and the pressure is applied through this knob. We rotate this drum, and when the cornea is flattened accurately according to the intraocular pressure, this will curve, get a separate curve. In this, inner margin of this half circle matches with inner margin of this half circle, and the reading is direct here. You can read it. You can see it's 3 inch. 3 means 30 millimeter of Hg. It means that patient is having 30 millimeter of Hg of intraocular pressure. Other types of tonometers are also there, and nowadays very popular in the hospital setup or in screening is non-contact tonometer, in which air puff is used for flattening the cornea. Similarly, if you have irregular scarred cornea, you can use Mackay mark type of tonometer, tonopen, or rebound tonometer. But when the patient is in supine position, as in general anesthesia like children, you can use Seward tonometer or Perkins tonometer. Intraocular pressure in the eye. But this is not a static thing. This varies throughout the day. Especially it rises at the midnight and keep on rising till early in the morning, even in normal person and more in glaucomatous patients. We call it diurnal variation. You may get a normal intraocular pressure in evening, but the intraocular pressure may be high in the morning. So, for proper assessment of intraocular pressure, we need to measure this diurnal variation also. So, we all know that the normal route of aqueous flow is from posterior chamber through pupil into the anterior chamber, then into the trabecular meshwork and Slem's canal, trabecular meshwork, Slem's canal, and episcleral vein or suprachoroidal. But many a time, the structures of this angle may get deranged, and the iris may be opposing the angle and blocking the Slem's canal, trabecular meshwork and Slem's canal pathway. So the aqueous will not pass through the usual route. It will keep accumulating into the anterior chamber and posterior chamber also. And this will again cause raised intraocular pressure. Here in this, since the angle is closed, we will call it raised intraocular pressure due to angle closure, and this can lead to angle closure glaucoma. But when the angle is open, still there is resistance in the trabecular meshwork or into the Slem's canal or through the episcleral vein also, because of various reasons, and the angle is open, we will call it open angle glaucoma. So the next thing which you will have to measure or see is angle of the eye, and this is seen with the help of gonioscope, and the process of seeing the angle of the eye is called gonioscopy. Angle of the eyes cannot be seen directly, so certain modification over the surface of the eye, that is over the cornea, is needed. So different types of gonioscope has been developed. In one which is more popular is mirror type. Here the light, the angle are seen in this mirror, and from here you can see through this. And another type is direct, in which direct angle can be seen from the side. Here there is no reflection. In indirect type there is reflection, and so there is inversion of the image due to mirror. The most popular gonioscopes are either 4-mirror gonioscope. They are very small and easy to apply, and then they don't need any coupling fluid between the cornea and the gonioscope, but other is Goldman 3-mirror or single mirror. And all these, if in a when the intraocular pressure is not normal and it is above the desired pressure, that is usually more than 23 millimeter of Hg or high, it can cause loss of ganglion nerve cell fiber, ganglion nerve cells. So the ganglion nerve fiber layer is lost. The distribution of ganglion nerve fiber in our eye is typical in pattern. You can see the nerve fibers coming from periphery going into the disc, optic disc, converging into the optic disc from side, but the fibers coming from fovea are on the most temporal side, and they will never cross this horizontal raphe. All the nerve fiber from above will enter into the optic nerve through upper side, and lower nerve fiber from lower side. And if there is loss of nerve fiber layer, you can see it in red free light, because this luster here is lost. This is called wedge defect. This is one of the early signs of glaucoma. This typically occurs in this zone, inferiorly or superiorly. And due to loss of ganglion cell layer, the corresponding loss in the visual field is also there. As we know that inferior retina will see the superior part, so the loss of any inferior nerve fiber layer will cause scotoma that is loss of vision as compared to its periphery from the in upper part. So you can see the glaucoma, presence of glaucoma or progression of glaucoma by evaluating the optic disc also. So a typical optic disc is made up of nerve fiber layer dipping into the scleral opening, and this will be made because of optic nerve fiber layers. But the central portion will not be having any nerve fiber. So the central portion will be seen pale in color, and the whole disc is this. So there will be a neuroretinal rim in between the pale and the margin, disc margin. Disc margin is here and the pale cup is here. And this pink color is because of neuroretinal and nerve fiber layer. So we can call that this is a disc here seen in the blue color, and this is white is the cup in the disc, and the area between the yellow and blue is neuroretinal rim. With progressive loss of nerve fiber layer, the neuroretinal rim will continue to get thin. So there will be progressive thinning of the neuroretinal rim, and at the end stage the neuroretinal rim will be lost. Meaning thereby loss of neuroretinal rim means loss of ganglion nerve fiber layer. ganglion cells and its nerve fiber layer. So in the normal condition, if you see, most of the disc will have a very thick neuroretinal rim. If you divide this optic disc into three parts, you will have 1, 2 and 3. So this one part and this one part. So white part, that is cup, is around 1/3 of the total area of the total length of the optic disc. So we write it like 0.3, C is to D is 0.3 is to 1. Similarly, here you can see that here it is almost total loss, around 9.95 cup is to 1 optic disc. So evaluation of disc can give a very good clue for the diagnosis of glaucoma as well as progression of the glaucoma.
Thank you.